Okay, the type of amyloidosis, AL for immunoglobulin light chain fragment, kappa or lambda immunoglobulin due to myeloma, Waldenstrom's, MGUS, untreated rheumatoid arthritis. Features will include restrictive cardiomyopathy, peripheral and autonomic neuropathy, carpal tunnel syndrome, hepatomegaly, nephrotic syndrome, severe diarrhea, spontaneous purpura. Macroglossia occurs rarely but is pathognomic. Prognosis is poor, so AL poor. AA amyloidosis. A is a precursor for serum amyloid A protein and acute phase reactant, seen in chronic infection, inflammation, TB, bronchiectasis, rheumatoid arthritis, and features renal involvement. Most common feature, so kidney. AB2 beta 2 M amyloidosis. Precursor protein is beta 2 macroglobulin, part of the major histocompatibility complex and associated with patients on renal dialysis. It's important for this. Features carpal tunnel syndrome and joint problems. Then there is ATTR. There's hereditary systemic and amyloidosis. ATTR is basically senile normal transthyretin protein deposit in tissues. Aging people more than 70-year-old, asymptomatic, may progress to cardiomyopathy. And then hereditary systemic amyloidosis, 20% more than that is systemic amyloidosis. Features can be peripheral autonomic neuropathy, cardiomyopathy, and renal involvement, usually unusual. 10% of the genetic carriers are asymptomatic throughout life. Okay, so this is part 2. This is management of AL type. Most common effective treatment is autologous bone marrow transplant with stem cell rescues. However, many patients are too weak to tolerate this approach. Other treatments can involve application of chemotherapy, and similar to that is in multiple myeloma. Combination of bortezomib, dexamethasone has been proposed as melphalan and dexamethasone BD. Digoxin is contraindicated cardiac amyloidosis, restrictive cardiomyopathy. And cardiac amyloidosis presents a restrictive cardiomyopathy associated with AL amyloidosis, of course. Stiff, rigid muscle wall, lack of efficient blood flow. So presentation can be presentation of right heart failure, jugular venous distension, peripheral edema, orthopnea, and paroxysmal nocturnal dyspnea are typically absent. So this left heart failure features. So this right heart failure features are more common. In more advanced systemic systolic dysfunctions also occurs. Combination of low voltage ECG and thickened ventricular walls is one of the characteristic feature of cardiac amyloidosis. Echocardiographic abnormalities include dilation of atria, thickened interstitial septum, and combination of low ECG, low voltage ECG and thickened ventricular wall is one of the characteristic features of cardiac amyloidosis. Echocardiographic abnormalities include dilatation of atria, thickened atrial septum, diastolic dysfunction, and small volume ventricles. The most distinctive feature of cardiac amyloidosis is a sparkling granular appearance of myocardium, granular appearance, and but this is a relatively insensitive feature occurring in only about 25% of the cases. Very common topic in hematology is splenectomy. Splenectomy is following a splenectomy, patients are particularly at risk from pneumococcus, Haemophilus meningococcus, and Capnotophaga canimorphus, chill from a dog bite infections. So vaccination, if elective, splenectomy, it's a very common question. Should be done 2 weeks prior to the operation. Very common question. And pneumococcal HIV, meningitis ANC, and annual influenza vaccination should be given. And antibiotics prophylaxis. All patients can be offered lifelong antibiotic prophylaxis. The increased risk of infection in patients with hyposplenism is lifelong, but is highest early after splenectomy. The biggest risk being from pneumococcal infection. So patients deemed to be at high risk, age less than 16 or more than 50, inadequate serological response to pneumococcal vaccination, a history of previous invasive pneumococcal disease, splenectomy for underlying hematological malignancy, particularly those who have received splenectomy radiation or who have ongoing GVHD are also at continuing risk. Prophylactic antibiotic is guided by our local antimicrobial guidelines. However, the most commonly used ones are penicillin 250 mg BD and also clarithromycin 250 mg BD if penicillin allergic. So penicillin 5 is the one. So what are the features you see in a patient of hyposplenism? You'll see splenectomy, what the causes of hyposplenism: splenectomy, sickle cell disease, celiac disease, dermatitis herpetiformis. All these are in the same group. Graves' disease, SLE, amyloid. So also in these ones you'll see some hyposplenism. Howell Jolly bodies, siderocytes. Okay. There is a classification of anemia given here, and you note here that it's like decrease MCV and decrease MCH to check up ferritin if it's iron deficiency or not. Target cells, we check hemoglobin electrophoresis, HbA2 increased beta thalassemia, HbA2 normalized alpha thalassemia maybe, dimorphic bone marrow sideroblastic maybe, and non-specific is like check iron and that for anemia, and if in case MCV is increased, check for history of alcohol or liver disease, family drugs. Blood film we check for dimorphic, check blood marrow, the previous one also. If it was dimorphic, check bone marrow for sideroblastic anemia. So then if there is cytopenia or dysplasia, check marrow again. Target cells, stomatocyte, check liver function. Hybrid segmented neutrophils, check for B12 deficiency as well. Alright. Okay, so going to macrocytic anemia, important factor, can be divided into causes associated with a megaloblastic bone marrow and those with a normoblastic bone marrow. So normoblastic or megaloblastic. So megaloblastic, let's see first. Vitamin B12 deficiency, folate deficiency, the classic ones we know about macrocytic anemia, these two. Then cytotoxic like hydroxyurea. Normoblastic can be alcohol, liver disease, hypothyroidism, pregnancy, reticulocytes. So like some of the general causes, reticulocytosis, like hemolysis, aplastic anemia, myelodysplasia, cytotoxics, drugs. It's important in patient who is also deficient in B12 and folic acid to treat the B12 deficiency first to avoid precipitating subacute combined degeneration of the cord. So something we've already studied before. And now iron deficiency anemia of chronic disease versus anemia of chronic disease. So it's all the parameters are given. If you see hemochromatosis where there's iron and ferritin going up, total TI's transferrin iron saturation percentage is more, TIBC is low, hemoglobin is normal, transferrin is low. Iron deficiency anemia, of course, hemoglobin is low. This TIBC is high, then ferritin iron storage is low. Sideroblastic anemia, you'll see hemoglobin is normal again, but these ones are high. Thalassemia, you'll see these ones are low, these ones are high. PCT, similarly, all that. Yeah, just have to check. This is a common question in clinical practice where both may show decreased MCB, MCH. Checking serum ferritin transferrin will determine if the cause of microcytic or hypochromic anemia. Unexplained iron deficiency may warrant GI referral for endoscopy, while ACD may need addressing the cause rather than giving iron supplement. Intravascular, extravascular hemolysis. So a common question once again. So in intravascular hemolysis, free hemoglobin is released, which binds to haptoglobin. As haptoglobin becomes saturated, hemoglobin binds to albumin, forming methemoglobinemia, detected by SCOMS test. Free hemoglobin is excreted in the urine as hemoglobinuria and hemosideruria. So the one we make mnemonic was with intravascular. You have to check mismatched blood transfusion, G6PD deficiency, red cell fragmentation, heart valves, TTP, DIC Hus, paroxysmal nocturnal hemoglobinuria, cold. So intravascular. And for extravascular will be abnormal red blood cell shape like hemoglobinopathy, sickle cell, thalassemia, hereditary spherocytosis, hemolytic of newborn worm, autoimmune hemolytic anemia. Next is SCOMS test. This is to check for autoimmune hemolysis. used to detect antibodies or complement proteins that are bound to red blood cell. A blood sample is taken and the red blood cells are washed, removing plasma, and then incubated with anti-human globulins. If this produces agglutination of red blood cells, the test is positive and an indication that antibodies are bound to the surface of red blood cells. So whether antibodies are there or not, so we check that. The Interarc is used in the prenatal testing of pregnant women and prior to blood transfusion. It detects antibodies against red blood cells that are present unbound in the serum. In this case, serum is extracted from the blood and the serum is incubated with red blood cell of unknown autogenicity. So agglutination means positive. Okay, moving to autoimmune hemolytic anemia. May be divided into cold and warm types according to at what temperature that the antibodies best cause hemolysis. So it's most common. It's most commonly idiopathic, but may be secondary to lymphoproliferative disorder, infection, or drugs. Autoimmune hemolytic anemia is characterized by a positive direct antiglobulin test, like direct Coombs test. So direct Coombs test will be positive, so it's autoimmune hemolytic anemia. So we divide it into warm and cold. Okay. So cold, let's see. Usually IgM mediated and causes hemolysis at best at 4 degrees, as said. Cold. Hemolysis is mediated by complement and is more commonly intravascular. So intravascular cold usually. Features may include symptoms of Raynaud's, hands become cold, it's all cold. Acrocyanosis, patients respond well to steroids. Okay, steroid works. Causes can be neoplasia like lymphoma, infection like mycoplasma and EBV. SLE can rarely be associated with a mixed type autoimmune hemolytic anemia as well. So it's all like cold and intravascular. Remember the causes infections like mycoplasma, EBV, they are all part of cold and autoimmune hemolytic anemia. And for worm, it's usually IgG causes hemolysis based at body temperature, and hemolysis tends to occur at extravascular sites. For example, the spleen. Management includes steroids as well. Immunosuppression and splenectomy can help. Autoimmune disease like SLE, neoplasia, lymphoma, CLL, methyldoma. Microangiopathic hemolytic anemia, MAHA, also known as that. And all these three, let's see, TTP, HUS, DIC, all these three actually is part of cold autoimmune hemolytic anemia. No, it's actually intravascular hemolysis. Intravascular hemolysis. Okay. Hemolysis by prosthetic. So this one also includes hemolysis by prosthetic valves, malignant hypertension, septicemia, vasculitis, connected disease like PAN and vagueness and SLE. So all these are MAHA. Fragmented RBCs. Remember that. So this is schistocyte in in the hemolysis. Pernicious anemia. Pernicious anemia will have, it's a disease of the stomach that is characterized by megaloblastic anemia due to B12 deficiency itself, secondary to intrinsic factor deficiency and gastric atrophy. So it is usually has an autoimmune basis. Treatment is aimed at correcting the vitamin B12 deficiency. Epidemiology can be most patients more than 60 years of age, less than 10% case, less than 40 years of age, is rare in children. 3:2 female more than male. Common in the first degree relatives in both blood group A and those with fair or prematurely gray hair and eyes and blue. Shaded with autoimmune disease like Addison's. Increased risk of gastric carcinoma. And investigation can be anti-gastric parietal cell antibody 90% and anti-intrinsic factor antibody 50%. So parietal cell antibody. Microcytic anemia more Mrcp, less WBC, less platelet. LDH may be high due to ineffective erythropoiesis. Decreased serum B12, hypersegmental polymorphism and film skilling test. Okay. Retrievable B12 given on 2 occasions, first on its own, second with the volunteer factor. Then B12 urine is measured. Sideroblastic anemia. It's a condition where check dimorphic. I think this. It's a condition where red cells fail to completely form heme, where whose biosynthesis takes place in the mitochondria. This leads to deposits of iron in the mitochondria that form a ring around the nucleus called ring sideroblast. Sideroblastic anemia, so there's a ring sideroblast like that. It may be congenital or acquired. So what happens is heme doesn't take place like completely form inside the mitochondria. So this leads to a deposit of iron in the mitochondria, forms a ring around the nucleus. So acquired is myelodysplasia, alcohol-led bromphenical anti-TB like pyrazinamide. Congenital can be DAS2 deficiency, delta aminoglobulin synthesis deficiency, and investigation can be hypochromic microcytic anemia. Bone marrow will show sideroblast and increase iron stores. Pyridoxine may help. So sideroblast you give B6. Important. Sometimes you may forget this one. This is very important disease. Next is pure red cell aplasia. Is diagnosed when there is an unexplained anemia and reticulocytopenia with a complete absence of red cell precursors in the bone marrow, but with preservation of other cell lines. Treatment is supportive plus immunosuppression with cyclosporin or related compounds. The condition can rarely occur where recombinant erythropoietin is administered, where anti-erythropoietin antibodies are detected. These patients respond to withdrawal of the erythropoietin with subsequent falling of the antibody levels. Association can be thymoma, autoimmune, lymphoproliferative disorder. Aplastic anemia. All the anemias are coming up together. So aplastic anemia is a rare condition characterized by decreased all pancytopenia and hypocellular or acellular marrow. So it's something with the marrow. So it's usually acquired through a congenital forms do exist, like Fanconi syndrome. The underlying cause is identified as less than 30% case of despite being extensive investigation. So management is supportive with blood products, prevention and treatment of infection, anti-thymocyte globulin and anti-lymphocyte globulin, prepared in animals or by injecting human lymphocytes. Highly allergic and may cause serum sickness, fever, rash, arthralgia. Therefore, steroid cover usually given. Immunosuppression using agents such as cyclosporin may also be given. Stem cell transplantation, allogenic transplants have a success rate of up to 80%. Fanconi is anemia. Is at autosomal recessive. Aplastic anemia may be there. Bone marrow failure, developmental abnormalities, cancer susceptibility, increased risk of AML. Neurological manifestations, skeletal abnormalities, skin pigmentation like cafe au lait spots. People with life expectancy of 16 years. Fanconi is anemia. Next is paroxysmal nocturnal hemoglobinuria, another intravascular hemolysis. So an acquired benign disorder linked to hemolysis, intravascular hemolysis, is thought to be caused by increased sensitivity of the cell membrane to complement due to lack of GPI. This is glycoprotein glycosyl. This PNH is a very rare disorder and should be suspected in confusing cases of hemolytic anemia. So type of hemolysis intravascular. Median survival is 10 years. So what happens? Let's see. GPI. So there are some pictures here given to understand this pathophysiology better. So GPI can be thought of as an anchor which attaches to surface membrane with the cell membrane. Okay, cell surface is there. Complement regulating surface proteins DAF are not properly bound to the cell membrane due to lack of GPI. So if there is lack of GPI, there's lack of GPI. So what happens? Thrombosis is so DAF doesn't really get attached to the cell membrane. So thrombosis is thought to be caused by a lack of CD59 on platelet membrane, predisposing to platelet aggression. So a lack of GPI is actually causing a lack of CD59 as well. So thrombosis is being caused, and this is happening in platelet. So on platelet membrane, lack of CD59 on platelet membrane predisposing to platelet aggregation. So lack of CD59 causing platelet aggregation. So diagnosis can be flow cytometry of blood to detect low levels of CD59, CD55. So you check, and DAF, you check all these three to flow cytometry, and has now replaced Ham's test, which is the gold standard. So now this is the gold standard, and Ham's test was different. So features can be hemolytic anemia, RBC, WBC, so stem cell may be affected, therefore pancytopenia may be present, hemoglobinuria, and classically dark colored urine in the morning. Patients are more prone to Budd-Chiari syndrome like venous thrombosis, it's an important feature, and aplastic edema may develop in some patients. So pancytopenia may occur, and there's dark colored urine, and then there's chances of venous thrombosis, Budd-Chiari syndrome, all these in PNH. So replacement management can be blood product replacement, anticoagulation should be important. Esolizumab is a monoclonal antibody directed against terminal protein C5, is currently being trialed and is showing promise in reducing intravascular hemolysis. Stem cell transplantation can also be a treatment. So basically it's intravascular hemolysis due to lack of GPI, which protects CD59. Due to CD59 there is more thrombosis. Polycythemia. Polycythemia may be relative primary polycythemia rubra vera or secondary. So primary is the one which you always see. So for primary is basically relative cause can be dehydration and stress like icebox syndrome. Polycythemia rubra vera can be primary cause, and secondary cause can be COPD, altitude, obstructive sleep apnea, excessive erythropoietin, cerebral hemangioma, hypernephroma, hepatoma, uterine fibroids. So differentiate between primary or secondary polycythemia and relative polycythemia cell mass studies are sometimes used. In true polycythemia, the total red cell mass in male is more than 35, women more than 32. Erythroid colony studies. Autonomous growth of erythroid colonies is taken as a sign of primary polycythemia, where erythropoiesis has escaped the control of erythropoietin. Erythroid colony studies are thought to have high specificity for detecting primary versus secondary polycythemia. So this can be used. Uterine fibroids, menorrhagia, blood loss. Polycythemia is rarely a clinical problem. Menorrhagia can have polycythemia, as in uterine fibroids can have that. So polycythemia rubra vera, the primary polycythemia, it's a myeloproliferative disorder caused by clonal proliferation of myristoyl leading to increased red blood cell, often accompanied by increased white blood cell and platelets as well. So these are accompanied. It has recently been established that a mutation in JAK2 is present in approximately 95% of the patients with PRV, and this has resulted in significant changes to the diagnostic criteria. The incidence of PRV peaks in the sixth decade of 50 to 60, with typical features like hyperviscosity, pruritus, splenomegaly. Complications include arterial and venous thrombosis, and PRV showed some association with Budd-Chiari syndrome as well. So at 30% progresses to myelofibrosis as well, while a significant percentage of patients develop an acute leukemia, is more common. So it is more common. So the features will be, as said before, hyperviscosity. The symptoms of hyperviscosity can be headaches, tinnitus, visual disturbance, cyanosis, joint pain, pruritus, typically after a hot bath, splenomegaly, hepatomegaly, hemorrhage, secondary to abnormal platelet function not number, plethoric appearance, low ESR, hypertension of the third of patients, increased hemoglobin and hematocrit, investigation, detection of JAK2, increased LAP. That's why it moves towards myelofibrosis. As we know, myelofibrosis has more LAP. Additionally, is more white blood cell and platelet, then increased plasma volume, increased vitamin B12, red cell mass, and ESR decreases, erythropoietic level decreases. So the main primary management is venesection, as well as hydroxyurea, slightly increase the risk of secondary leukemia. Allopurinol, phosphorus 32. Prognosis: thrombotic events are a significant cause of morbidity and mortality. 30% of patients progress to myelofibrosis, and this is more number. 5 to 15% to acute leukemia. Following history and examination, the British Committee for BCSH recommends the following investigation: APC full blood count film, raised hematocrit, neutrophils, basophils, platelets raised in half of the patients, JAK2 mutation, serum ferritin, renal and liver test. All this can be checked. And then if JAK2 is negative and there are no obvious secondary cause, and BCSH suggests the following test: red cell mass, arterial oxygen saturation, abdominal ultrasound, serum erythropoietin level, bone marrow aspirate and trophon, cytogenic analysis, atrial plasmonic unit culture. So the diagnosis: JAK2 positive, PRV. Diagnosis requires more criteria to be present. If it's positive, high hematocrit or red cell mass, mutation JAK2. And if JAK2 is negative, PRV diagnose A 1, 2, 3 or either A or 2 from B criteria. Another AN criteria. Red cell mass increase, absence of JAK2 mutation, no cause of secondary erythrocytosis, palpable splenomegaly, presence of acquired genetic abnormality like this. In excluding this, in the hematopoietic cells, thrombocytosis, neutrophil leukocytosis, all these things. Not very important to remember maybe. And methemoglobinemia before we move to the inherited anemias. So what happens here is describes hemoglobin which has been oxidized from Fe2 to Fe3. So why is happening? This is normally regulated by NADH methemoglobin reductase, which transfers electron from NADH to methemoglobin, resulting in the reduction of methemoglobin to hemoglobin. This is tissue hypoxia as Fe3 cannot bind oxygen, and hence the oxidation to this curve is moved to the left. Methemoglobinemia is oxidation of Fe2 in hemoglobin to Fe3, so it cannot bind to oxygen, so it's moving to the oxidation curve to the left. Okay, so what happens is hemoglobin chain variants, HbA, HbH, NADH methemoglobin reductase deficiency. Like can be sulfonamide, nitrates, dapsone, sodium to nitric oxide primaquine, chemical like aniline dyes. So what happens is chocolate cyanosis, dyspnea, anxiety, headache, severe acidosis, arrhythmia, seizures, comas, and the normal PO2 but decreased oxygen saturation. And then a management can be NADH methemoglobin reductase deficiency, ascorbic acid, vitamin C, if IV methylene blue if required. Ascorbic. Let's see. Okay, so vitamin methemoglobin concentration 10 to 20%, skin discoloration only 20 to 30%, anxiety, headache, then last is high risk of death 5 to 70%, coma, seizures, there's dyspnea and tachypnea, all these things. Then comes hypoglycemia, spirit hydrosis, hematology. It's coming with this one.